Hi guys. My name is Luke Johnson. I'm a pediatric dermatologist and general dermatologist at the University of Utah here. And thanks to Intermountain Derm Society for letting Michelle, who's also here on the call, hi Michelle, and I host this first maintenance of certification part. This is a mockingbird up here on the corner, by the way. Ha ha ha. There we go. We are hosts of this podcast called Dermasphere, which brings you discussions about some of the latest research in dermatology so that you can get hopefully up-to-date information by listening through your ears rather than needing to read a bunch of journals and stuff. We've been going on for a couple years now. We've got, a bunch of episodes. We'd love to have you come check out the podcast. We don't get paid for the podcast. It doesn't cost you anything to use it. It's just out there because first it's fun to do and hopefully it'll keep you up to date and maybe even improve patient care. And because we're always reading the latest literature as part of this podcast, it seemed like a maintenance of certification thing would be kind of a cool way to leverage some of that information to something useful for the IDS members. So here we go. So I'm going to talk about the first 5 questions, and then I'll turn it over to Michelle for the second 5. So I've got until like 10:30, I guess. Should be enough for 5 questions. So the first question is, which of the following psoriasis biologic medications showed the greatest efficacy based on PASI scores in its clinical trials? Was it certolizumab, guselkumab, secukinumab, tildrakizumab, or ustekinumab? And I've got the brand names there too, just because I feel like some people are a lot more comfortable with them. My initial stem for this question was, which of the following is the best psoriasis biologic? The American Academy of Dermatology adjusted it a little bit, which I think was probably good. But a lot of you guys already did this quiz before this and have picked your answers. So if you haven't, silently commit to one of these answers. And if you picked guselkumab, then you would be correct. The brand name is Tremfya. Michelle and I think that Tremfya might sound like what a goose would sound like. So guselkumab, Tremfya. That's what we say on the podcast to help you remember which one's which. So this is PASI 90 scores at week 10 to 16 from a study I'll talk about in just a sec. So PASI 90, first of all, pretty amazing that we're talking about PASI 90, right? Hopefully we'll be talking about easy 90s with atopic dermatitis soon. So you can see that it was better than all these others that were listed on here. But still, I mean, even 39% PASI 90 is pretty good compared to what we were at 15 years ago. So this is from this article here from JAMA Dermatology, Comparison of Biologics and Oral Treatment for Plaque Psoriasis, a meta-analysis. We discussed this in episode 22 of the podcast. And this was a literature review of 60 clinical trials that were phase 2, 3, and 4 for adults with moderate to severe plaque psoriasis. And when I read this article, I thought to myself, oh my goodness, this statistical examination is so cool. How come we don't do more of this stuff where they actually look at all of the phase 2, 3, and 4 clinical trials for a variety of medications and compare them? So it was super neat first that this is something that smart people like these authors can do, and that it turns up with some pretty useful information in clinical practice. So here is a big busy table, but basically it tells you the PASI 75, 90, and 100, PASI 100 scores for all of these things that they were looking at. So if you want to take a moment to find whatever your current favorite is, you can see how it fares. And perhaps after this talk, your favorite might be something else. So all of these following were tied as the best at both short and long-term time points. So 3 months and 1 year were what they looked at. And this was, again, based on PASI scores. And these all, the numbers were a little bit different, but they were not statistically significantly different. So basically, brodalumab, ixekizumab, guselkumab, and risankizumab were all equivalent in terms of PASI clearance. And again, just as a way to help remember stuff, the IL-17 inhibitors are brodalumab and ixekizumab, and then guselkumab and risankizumab are IL-23 inhibitors. So all very good. But that doesn't tell the whole story, right? So just knowing how effective it is doesn't necessarily mean it's the one you want to use in a particular patient. So I thought to myself, What are the other things that I think about when I'm trying to decide what biologic to prescribe to somebody? Well, I think about how much it costs, and I think about how frequently it has to be dosed. So I looked up all that information. So this were costs based on GoodRx back around the time when this article was published. And you can see here the schedule for dosing and also how much this stuff costs. So guselkumab also wins as the least expensive of these options at $77,000 a year versus $104,000 and $182,000 for brodalumab. I guess as a society, we can decide if $77,000 a year is worth it for treatment, but it's the cheapest of these options. And also, I think the dosing schedule is pretty reasonable at week 0, 4, and then every 12 weeks thereafter. So for all of those reasons, guselkumab, in my opinion, is the best psoriasis biologic currently out there. So again, episode 22, and we have a little award show at the end of every year on the podcast where we give what we call the Dermy Awards to some of the articles that we discussed. And this one won the best overall article for 2020 for the reasons I've already mentioned. This was sponsored, so in the way of disclosure, it was funded by AbbVie, though satisfyingly, AbbVie does not make guselkumab, which I thought was especially nice. But thanks for AbbVie for sponsoring a cool study here. Okay, moving on to question 2. So based on recent literature, which of the following cumulative doses of isotretinoin is the lowest number associated with sustained remission of acne? 120, 140, 160, 180, or 200 milligrams per kilogram. Again, I know a lot of people have already had a chance to answer, but if you haven't, then silently commit to one of these. So we want sustained remission of acne with isotretinoin. What dose should we maybe target? And the answer is 160 milligrams per kilogram. So this is another study that we'll discuss in more detail in just a second. But when we say sustained remission, what I'm basically saying is this patient is less likely to need a second course of isotretinoin. And I know there's some old literature that says we should shoot for at least 120, but maybe that's not good enough. So that's from this article here, which we discussed in episode 39 by Patrick Tran and Carol Cheng et al. And it was a fairly straightforward study design. So they begin the study by talking about how previous studies have discussed acne recurrence after isotretinoin can be associated with several factors, such as the cumulative dose, the patient's gender. So male patients tend to need a second course more frequently. If the patient's younger, if the if the acne is more severe, and then the treatment duration. So these guys looked at a retrospective case control design, a bunch of patients from their institution, and they looked at people who recurred after getting isotretinoin, so basically needed a second course of isotretinoin, and the patients who didn't. So it was not a humongous study, but decently sized. So they had 160 patients who took isotretinoin and didn't need a second course, or at least didn't come back to their particular institution for a second course. And they had 82 patients who were on a second course of isotretinoin after, of course, completing the first one. So patients who did not require a second course were more likely to fulfill 2 criteria. First, they received a higher cumulative dose, 160 milligrams per kilogram versus the control patients who got 130 milligrams per kilogram. And they had been clear for longer before discontinuing isotretinoin. So again, like according to medical documentation, they were clear for 2 months before discontinuing rather than clear for 1 month in the recurrent group. So there was no association with age. Sorry, I heard somebody saying something. Am I somehow doing something wrong technologically? It's certainly possible. Let me know if I am. But in this study, there was no association with age, with acne distribution, with acne subtype, or with gender. So before we move on to question 3, this has probably impacted my practice more than just about any other article, even though it's very simple. I just prescribe a lot of isotretinoin. And so these days, what I tell my patients is, well, to know when we're done and make you less likely to need a second course, we want to get to a certain amount of medicine total in your system, so 160 milligrams per kilogram, and I want you to have been clear for 2 months before we stop. And I basically do that with every patient I have on isotretinoin unless there's, something else going on. Because as you guys know, it really sucks to clear somebody with isotretinoin and then have call your office 6 to 8 months later and you end up needing to put them on a second course of it. So hopefully this helps prevent us from needing to do that. Okay, question 3. Which of the following treatments is the most effective at achieving a 75% reduction in the number of actinic keratoses when measured at 12 months post-treatment? So perhaps a way to say this is which is the most effective at clearing actinic keratoses. In terms of sort of field treatment stuff, is it 5-fluorouracil, Keratage, imiquimod, ingenol, or photodynamic therapy? Silently commit. Most effective, 75% reduction, number of AKs when you're looking a year later. The answer is 5-fluorouracil. So here is the percent. So the endpoint in this study is a 75% reduction in AKs a year later. And 75% of the patients who were treated with 5-fluorouracil achieved that endpoint. Keratage, not exactly studied. All of the AKs were treated with Keratage prior to treatment, which is how they do it a lot in Europe, I think, which is where this study was done. And then you can see that imiquimod, ingenol, and PDT, just the numbers weren't as good. And this is from this study here from the New England Journal of Medicine, which we discussed in one of our demo episodes, though you can certainly still listen to it if you feel like it. It's also available as a bonus episode, but it's pretty exciting to see this published because it's like finally somebody did a head-to-head study on treatments used for a common condition. So they had 624 patients. The actinic keratoses they treated were on the head and neck, and they were randomized into these 4 treatment groups. So photodynamic therapy, again, this is in Europe, so maybe the protocol is a little bit different than it tends to be done here. So you can see here what they did. Ingenol, and then imiquimod, and then 5-FU, 5%. So interestingly, you had to go to their supplemental material to see the actual protocol they used for 5-fluorouracil. They used it twice a day for 4 weeks, which was like a lot, I thought, because prior to reading this article, I would have people do it for 2 weeks, and they were already complaining. So twice a day for 4 weeks was what they did, though. And then, as I said, Keratage in every lesion. They did have a couple, this one issue here where if they brought the patients back after 3 months, and if they weren't, at least 70%, 75% better, they would retreat them with whatever they used in the first place. And then we talked about the endpoint here already. And so we talked about these numbers here. They pointed out that 5-fluorouracil was also the most cost-effective of these options. And they said none of the 624 patients quit due to adverse effects, which I think is fairly impressive. And they said that despite what I may have thought, that 5-FU did not have more adverse effects than the other treatments that they tried. And the photodynamic therapy patients was the only group where there was a significant amount of people who said that they wouldn't want to do that particular treatment again. So in that sense, 5-FU was better tolerated than PDT. Maybe the PDT they use in Europe is less well tolerated here, but anecdotally, I felt that PDT was better tolerated than 5-FU, but in this study, that was not the case. 5-FU was better tolerated, which again is surprising because if you look up Efudex online and look up Google images, you find pictures like this and like this. But nowadays, I tell people, PDT or 5-FU is usually what I suggest if we want to do field treatment for AKs. I say the studies do say that the cream works a bit better, but you got to do it for 4 weeks. Okay, moving on to question 4. So surgical stuff, we cover all the bases in Dermasphere. So according to recent studies, which of the following is true regarding surgical technique and outcomes? Okay, so which of these is true? Closer together sutures result in better scars. Head and neck, trunk and extremities. Closer together sutures, better scars. 6-0 is equivalent to 5-0 for scar outcomes. Or wound aversion gives you better scars. Head and neck or trunk and extremities. Well, according to recent studies, the only one of these that is true is this one. Smaller sutures are equivalent to larger sutures for scar outcomes. And then there's a number of other recent studies that have looked into surgical technique and have called into question a lot of our aspects of surgical dogma, such as the efficacy of wound aversion and closely spaced sutures. When I was in residency, we had two different surgical directors over the course of my time there, and they were very different in terms of their approaches to surgical technique. One of them said, "You know what? It doesn't really matter exactly what you do. Everybody, it'll be fine. It'll be fine." And then the other surgical director said, "We must have meticulous technique to achieve exquisite outcomes." And it was interesting that they were both excellent surgeons and excellent mentors, and their approaches to sort of these questions of technique were so different. So it's interesting to see that, in my opinion, the literature is leaning more toward the former than the latter approach. So, for example, we discussed this article in episode 32 that wound aversion doesn't matter. So this was 50 patients. They had closures on the head and neck, and the surgeons sort of attended a little session on whether and how to make their closures everted or not everted, which they referred to as planar. They were all sewed up with the same technique, vertical mattress and running subcuticular sutures, and then they followed them 3 months later. And this POSAS, POSAS perhaps, is a validated scar metric. So both the physician and the patient rate the scar on several metrics with the POSAS, and then you can kind of compare the scores on individual aspects of the scar as well as the overall appearance. And the upshot is that it didn't matter whether you everted your wound or you used a planar closure. There was no difference in the POSAS scores afterward. And then a 2015 study by the same group came to the same conclusions. The study that I just mentioned, this one here, was on the face and neck, and then their 2015 study was on the trunk and extremities. So this picture down here is from Up to Date about proper surgical closure. You can see it recommends eversion, which we've been recommending for decades, but maybe it doesn't matter. This was the 2015 study here. And so this is the correct answer for the question here, 5.0 and 6.0 being equivalent here. We discussed in demo episode 3. So very similar study where they had, number of patients and split them into the 5.0 group and the 6.0 group. Again, this was head and neck, and again, used the POSAS score and found that there was no significant difference. And then here, this is the spacing question. So they, again, very similar study design, and they had a 2 millimeter versus 5 millimeter suture spacing. These patients served as their own controls. So they were had a surgical wound, and then they were randomized to the left or the right side of that wound, getting 2 millimeter or 5 millimeter suture spacing, which they measured with a ruler and marked out with a little marking pen. So patients serving as their own controls, pretty strong design, and again, found no difference. And then very similar study by another group looking at similar closures on the trunk and extremities, though. These folks compared 5 millimeter to 10 millimeter suture spacing. And again, there was no difference in the overall POSAS scores, except for a single metric on the POSAS remained significant between groups, even after 6 months later. The physician reported, quote, surface area metric on the POSAS was better in the low density group. So the low density is the sutures farther away approach. So really they're probably equivalent, but maybe slightly you can place them farther apart. So all of that stuff, obviously there's benefits to placing your sutures farther apart as well. It's faster, it uses less suture material. And then the idea about how it could possibly be a little bit better is, less inflammation, fewer pokes, less bleeding, all that kind of stuff. Okay, last question from my half of this talk. Recent research shows that short courses, so defined as 14 days or fewer, of systemic steroids in children, see, we covered pediatric dermatology too, are associated with an increased risk of what? So if you give somebody a little dose of prednisone or methylpred dose pack or something, what are you increasing their risk of? Is it fracture, glaucoma, pneumonia, urticaria, or venous thromboembolism? Take a moment, commit. The answer is pneumonia. And so the odds ratio of a child developing pneumonia after a steroid dose like this within the next 30 days goes up to 2.0. So in terms of the other answers, fracture is associated with steroid use, but in adults hasn't yet been shown in children. Glaucoma not shown to be a risk with these short courses of steroids. Urticaria wasn't studied, at least in the studies I looked at, but we use steroids to treat urticaria, so it doesn't seem like that would make a lot of sense. And then venous thromboembolism, like fracture, is indeed associated with systemic steroid use, but in adults, not kids, at least so far. So this out of JAMA Pediatrics, which we discussed in episode 55. This was a big data study from Taiwan. So in Taiwan, there's a national healthcare database, like there seems to be in just about every country but ours, and included 4.5 million children, which is something like 99% of the children in Taiwan. Shockingly, 23% of them had been prescribed a single steroid burst. So they didn't include patients who had been prescribed more than a single steroid burst, just to make their data as clean as possible. And they defined a steroid burst as systemic steroids for 14 days or less. And again, sort of like the split scar study, patients served as their own control. So they basically looked at the patient 30 days before their steroid burst, and then sort of 30 days afterward. They did have a little sort of window right around the steroid burst where they didn't actually look at it, presumably because whatever condition was related to them needing the steroid burst could have affected this, but basically sort of a before and after time point. And in the 30 days after the steroid bursts, the risks of several things increased. So the risk of GI bleeding, the odds ratio is 1.4, pneumonia 2.0, and then sepsis even higher at 2.2. And then the risks downtrended over the 60 days after that first 30 days, but still remain significant for, I believe, sepsis even up to 90 days after the steroid burst. So in my opinion, healthcare providers in general seem to prescribe systemic steroids more than I think is appropriate. So I'm always kind of looking for ways to hate on systemic steroids. Certainly there's times when they're appropriate. My own personal feeling is that they're kind of like opioids for pain management. They're good for chronic issues. So if somebody walked through a field of burning poison ivy and is horrible allergic contact dermatitis, I think prednisone makes a lot of sense. But they're bad for chronic issues. And in this case, a lot of the people prescribing the systemic steroids were not dermatologists, though a lot of dermatologists did prescribe them, but there were primary care doctors and allergists and people like that who were giving them for, URI symptoms and things. And the study points out that the data is kind of hazy on it. So a wake-up call perhaps for that sort of use as well, but I think for us as well to be cautious with systemic steroids. We talked about it in adults as well back in episode 9. So again, this is in the United States this time, and there was 1.5 million adults in a big insurance database that showed that in the month or so following a short, even 5 days, systemic steroids increases the risk of fracture, sepsis, and venous thromboembolism. So those methylprednisolone dose packs or those prednisone tapers are perhaps not as safe as we wish they were. And then the Annals of Internal Medicine in 2020 had another nationwide population-based cohort study, again from Taiwan, from some of the same people who did that study published in JAMA Pediatrics. 16 million adults this time. You can see that the odds ratio for GI bleeding goes up quite significantly, and then for heart failure and sepsis as well. So just a reminder of what we just discussed over the past 30 minutes. So we talked about what's the best psoriasis biologic. In my opinion, based on this study, it's guselkumab. We talked about isotretinoin. This study suggests that you should treat to 160 mg per kg in 2 months past clearance. We talked about 5-FU seems to be the winner for actinic keratoses if we indeed believe that your patients can tolerate it, BID for 4 weeks. Perhaps we learned that wound aversion doesn't matter. And we learned that systemic steroids have risks even when they're used for a pretty short duration. That's all for now, though if you like Intermountain Derm Society, I hope that you will also enjoy Dermasphere, because as I was listening to our previous speakers, I thought to myself, wow, we've discussed that on the podcast. Oh, we discussed that too. So you can see we've discussed bapomas, the use of PRAME, that BEEP trial that perhaps showed that atopic dermatitis is tough to prevent by moisturizing children. We discussed the use of dupilumab for little kids, even under 6. So if you want evidence to throw at the insurance companies or some dosing information, there's that there. And then upadacitinib, I'm with Dr. McGinnis. That looks pretty exciting for atopic dermatitis. But I don't know if I'm supposed to take questions since I'm the one asking you questions, but it's 10:26. So maybe I have 4 minutes before it's officially Michelle's time.
Yeah, does anyone have a question based on any of those studies for Dr. Johnson before we turn it over for part 2?
So Luke, you said the one article that influenced your practice the most was the one about treating 2 months fast clearance for isotretinoin. Which one do you think you've pimped the most residents over?
Oh,
Oh, yes, and we have the pimping bell. So if you've not listened to Dermasphere, we have our pimping bell, and we ring that whenever there's pimpable content. So this is stuff that would be good to show up on a test, or things that would be good to ask residents if you're training them.
off the top of my head, I don't know, but I do find that just doing the podcast has influenced my practice in a lot of ways. It's pretty common that I find myself telling the residents, we discussed this on the podcast, so I think we should do something. So even if nobody else listens to it, it's helped me.
Thank you, Luke. Okay, I'll have you turn over to Michelle as the host. And then
So I'll stop sharing.
Yeah, stop sharing. And then if you hover over her name, you should be able to enable her as the host now.
And then Luke, there's a question in the chat that I think that you could help address.
Okay.
Oh, yes. It says,
Right.
I'm a family doctor and don't understand how do you calculate 160 milligrams per kilogram cumulative? I usually give 40 BID. How does that equate?
Okay, it's super easy. So you don't actually have to calculate, you just calculate how much medicine you've given the patient rather than and assume they've basically taken it all. Because every so often you get somebody who's like, I still have a week's worth of medicine, but you don't have to worry about that. Just worry about what you've prescribed them. So if you give them 30 days worth of 40 milligrams BID, then that's 30 times 80 milligrams a day. So I'm putting this in the chat here. So that's 2,400. And then you divide that by their weight in kilograms. And not by their weight, by their weight. This isn't Game of Thrones. And you come up with some number like, oh, they've now been taking 20 milligrams per kilogram of their body weight. And so if you give people something like 40 mgs BID, and most people would probably hit 160 in, depending on how big they are, probably 5 to 8 months. So in sort of the standard, like 1 milligram per kilogram per day dosing of Accutane that most of us, I think, do, you get there in 6, 7, sometimes 8 months. I find that sometimes I have to go to 180 or 200 milligrams per kilogram to get people to the clear for 2 months metric. And the way I approach that with patients is I say, if they say, well, I had a few pimples maybe 4 or 5 weeks ago, but now, now they're clear and they're at 170, I still say, since you're tolerating the medicine so well, just to give us the best chance of not needing it again, I think maybe we should go for another month. And they usually say, all right.
Does that help answer that question? And then can y'all tell me, are you seeing the speaker view or the full screen?
Right now, we
do not see the speaker view.
You're seeing the speaker view? That always happens.
No, I don't see the speaker view. Do you see the speaker view?
No, we're just seeing your slides.
You see the full screen slide. Okay, perfect. Awesome. Yeah, so I think that calculating those cumulative doses are confusing a little bit, but you kind of realize that if you have a person who is like 75 kilograms, you multiply your goal dose times their weight, which gets pretty high. It's almost like 12,000 milligrams. And then you have to figure out how to get there over 6 months. So most patients can get there over like 6 to 7 months, depending on how you dose them. But that was a great question. Well,
Jason Mathis has a different approach that also works just fine. He put it in the chat there.
I like that also. I think it's really good also to like sort of describe your goal dose at the beginning of the notes so you know where you're headed. Well, thank you guys so much for having Dermasphere here. We're so excited to be a part of this conference and just share our learning with you. Just like Luke, I take so much enjoyment in learning from participating in Dermasphere, and I love teaching. So this is the Maintenance of Certification Part 1, second portion of the talk. And so I am Michelle Tarbox. I'm an associate professor of dermatology and dermatopathology at Texas Tech University Health Sciences Center in beautiful sunny Lubbock, Texas, and also the co-host of the Dermasphere podcast. I'm also a self-proclaimed dermoscopy nerd, which does feature in one of the questions. I have no conflicts of interest to disclose, except that I love medical dermatology, dermpath, and dermoscopy. So I've got med derm, dermpath, and dermoscopy. And doesn't this look like a little rabbit to anybody else? I just think it's so cute. I also am a teacher of residence. So this is my current residency class in what I call our Last Supper photograph. So they just decided to take this goofy photograph together, and I thought it was so perfect and wanted to share this. And I have enjoyed being a teacher of residence for a long time, even back when one Luke Johnson was a resident. So this is actually a party we had at Luke's house. So here's me and here's Luke. And this was a murder mystery that we did in costume, which was really hilarious. So I was Lady Yoda and Luke was, were you an expendable crewman? I can't remember what your character was.
I was Captain Jerk, I believe, according to the script.
Oh yes, yeah, they had all sorts of characters in the script, which were hilarious. So some of my questions come from Dermasphere and some of them come from my clinical practice, questions that have come up training my residents, and of course, things that happen when you're a dermoscopy nerd. So we'll kind of talk about lots of different things this morning. Our first question here, a 28-year-old female patient comes for consultation for recalcitrant hidradenitis suppurativa, also complaining of irregular menses, weight gain, and hirsutism. Patient is a vegan and wants to avoid further antibiotics if possible. I think many of us have treated this patient. I call these my crunchy granola patients that don't really want to have chemicals or things like that. So she wants to have a different therapeutic option. So which of the following options could potentially predispose this patient to a vitamin B12 deficiency? And of course, the stakes are higher because she's a vegan. And so our options here are adalimumab, spironolactone, zinc, metformin, or finasteride. Now, of course, vegans can get adequate B12, but they have to supplement because it's only present in mammalian food sources. And of course, the right answer here was metformin. So this was our spread on the answers. Here's an article highlighting the association between metformin dose and vitamin B12 deficiency in patients with type 2 diabetes. So anywhere between 6 and 30% of patients on metformin could show a B12 deficiency due to metformin use. And in some studies, the serum B12 levels were inversely related to the duration and dose of metformin usage. Especially if you get over 1,500 milligrams per day, it could be a major factor related to B12 deficiency. And concurrent supplementation might potentially protect against the deficiency as well as the anemia and peripheral nerve damage that could happen, which could exacerbate coexisting peripheral diabetic neuropathy. So we, in episode 5 of Dermasphere, talked about the HS guidelines, parts 1 and 2, which were published in the JAD. And one of the treatments highlighted in part 2 of this article series, which was excellent, was the use of metformin at 500 milligrams 2 to 3 times daily, which was associated with significant improvement in Sartorius score in patients with hidradenitis suppurativa, as well as an improvement in the Dermatology Life Quality Index, which we talk about in a lot of the articles that we review on Dermasphere. It's a repeatable method to kind of assess the effect of a dermatologic condition on a patient's quality of life. And one of the metrics that we have to help demonstrate the necessity of a medication. So understanding it and being able to use it, I think, is very good for dermatologists in clinical practice, as well as those of us educating residents. They showed that there were improvements again in that DLQI in a 24-week uncontrolled prospective study. Most of the patients were females with features of PCOS, like this patient that we described in the question stem. Our other options here, adalimumab doesn't really cause any vitamin deficiencies. However, there is data that supports the possibility that TNF-alpha inhibitors might work better in the setting of optimized vitamin D levels. Spironolactone really doesn't affect B12 levels, neither does finasteride. Zinc doesn't impact B12, but it does have an inverse relationship with copper. And sometimes we do use zinc in our crunchy granola patients to treat things like acne and sometimes also hidradenitis suppurativa. So remembering that association is a good idea. This is my dermoscopy nerd question, so I had to bring this one to the fore. A 70-year-old man presents with a lesion shown. Biopsy shows bone invasion. After starting on an oral medication for treatment, he complains of a metallic taste in his mouth. How does this drug work? So when we're training our residents, we talk about questions that are double and triple jump. So here you have to first make the correct diagnosis by looking at the clinical and dermascopic image. Second, you have to know about which medications are used to treat that particular neoplasm. And then third, you have to know the mechanism of action of the drug tied into its side effects. So there are multiple jumps in this question, and it tests multiple areas of knowledge. So of course, getting the right answer here keys upon making the right diagnosis of what tumor you're looking at. And I made it hard because I am a dermoscopy nerd. And so the right answer here is smoothened inhibition. So my dermoscopy nerd hat said, pick a mean one. And I did. So I apologize if this was difficult, but we're going to go over the features that tell you what this lesion is. So this lesion, of course, is a pigmented basal cell carcinoma. And the correct answer is vismodegib, which works through smoothened inhibition and can cause a metallic taste in the mouth, amongst other side effects. So it was a mean question because some people, I believe, thought this might have been a melanoma, and BRAF inhibition would potentially be a therapeutic choice in that setting. So here we go, our correct answers here. These are the dermascopic and clinical findings of a pigmented basal cell carcinoma. Over here on the left, we can appreciate that we have these blue-gray ovoid nests and arborized telangiectasias that are very crisply visualized. And the reason for that is that basal cell carcinomas have a very mucinous stroma. So you can see the vasculature quite crisply, and you can appreciate that branching architecture because that tumor is going, feed me, Seymour, and it's asking for more blood supply. So you have these big arborized telangiectasias. I like to describe these to my patients as these are blood vessels that have a job. These are the, businessman in New York City walking to work in the morning. He's in a straight path. He's going somewhere important. And so we've got here our branched and arborized telangiectasias. So this patient who has a basal cell carcinoma is being treated with vismodegib. Taste disturbance can occur in up to 75% of patients on treatment with vismodegib, which can work through smoothened inhibition. This is an article that highlights some of the dermascopic features of pigmented basal cell carcinoma and basal cell carcinoma in general. Briefly to review those, that arborized telangiectasias, those are going to be present when you can see them nice and crisply because of that mucinous stroma, and they have a job, they're being recruited to the tumor. The blue-gray ovoid nests, these occur because the melanocytes will sometimes get into a nodule of basal cell carcinoma. Now remember, melanocytes think they're supposed to be in contact with basal cells in the epidermis. They feel them, and their little integrins go, this is a basal cell, touch and bind to this. And so if melanocytes get into a nodule of basal cell carcinoma, they get a little confused and they're like, oh my goodness, there's friends everywhere. I can just be all over this. And so they make this happy little network of dendritic melanocytes that colonizes the basal cell carcinoma and makes pigment. And so that's what's creating this finding of these blue-gray ovoid nests, which can be quite heavily pigmented and can make the lesion look somewhat like a melanoma. There have definitely been pigmented lesions I've biopsied in my career where I'm going, please be a pigmented basal cell. Please be a pigmented basal cell, because it's the lesser of the two evils under those circumstances. You can also sometimes see some areas where you have a little bit more leaf-like area. These are kind of the maple leaf areas we described. These are the edges usually of a pigmented basal cell where that same phenomenon has happened. You can get ulceration and hemorrhage because basal cell is not very good skin. And of course, you can also see some areas where you have smaller blue-gray ovoid nests. Our incorrect answers included BRAF inhibitors. So they can cause cutaneous eruptions, keratotic squamoproliferative lesions, and photosensitivity. They're used to treat a variety of malignancies, including melanoma, but not for basal cell. Janus kinase inhibitors can increase the risk of infection and may also cause mild increases in cholesterol and cytopenias. They can be used to treat inflammatory conditions, but not basal cell carcinoma. TP53 inhibitors can be beneficial in treating small cell lung cancer of the head and neck. They can cause fatigue, dizziness, and headache or confusion, but we don't use these for basal cell. And tyrosine kinase inhibitors, such as imatinib, can block other activated receptor tyrosine kinase activities, such as c-KIT. So the activities of this particular class of drugs can cause adverse effects, including upset stomach and nausea, vomiting, diarrhea, muscle and joint pain, cramps, dizziness, and blurred vision or drowsiness. And it can be used to treat things like GIST, so gastrointestinal stromal tumors. One of the other hats I wear, of course, is as a pathologist. And so these are a fascinating class of tumors that can be treated with tyrosine kinase inhibitors, as can unresectable dermatofibrosarcoma protuberans. But basal cell carcinoma has not been one of the drug targets for imatinib. Another crunchy granola patient here, another nice stock photo. I liked this man's friendly face. You are treating an otherwise healthy 55-year-old man suffering from pudendal dysesthesia following many years of competitive cycling. He has pursued multiple complementary and alternative medicine therapies to help address this issue. And unfortunately, after doing that, he develops hypoglycemia relating to loss of consciousness and a blood glucose level of 27 milligrams per deciliter. A high insulin level and high titers of insulin antibodies were detected using the normal serologic testing, and you find a diagnosis of insulin autoimmune syndrome. So which of his crunchy granola treatments may have potentially caused this? Curcumin, cannabinoids, alpha lipoic acid, acupuncture, or benfotiamine? The correct answer here is alpha lipoic acid. So this is our spread on people's choices of the answer in the pre-quiz. And here are some articles in the literature discussing the presentation of insulin autoimmune syndrome in patients taking alpha lipoic acid. This highlights something that I want to bring forward always when I'm teaching residents, which is case reports can create signals in the literature, and those signals in the literature can then be taken forward to do more of a systematic review and find things that it might be actually an important fact that we can discover through reporting these and sharing our knowledge with our colleagues. So a scientific opinion was done on the potential relationship between alpha lipoic acid and the risk of insulin autoimmune syndrome. And they found 49 case reports that showed that IIS could develop following alpha lipoic acid consumption. And fortunately, they would resolve after discontinuation of the drug. This is some of the tabular review of that data, showing each one of these little case reports that made a signal in the literature. So we found that insulin autoimmune syndrome or Hirata disease, which is a rare cause of autoimmune hypoglycemia with high insulin levels and anti-insulin antibodies, could occur amongst patients who are supplemented with alpha lipoic acid. And they think that this is because of the sulfhydryl containing portion of alpha lipoic acid. This condition was first described in 1970 in Japan by Hirata, and it's usually caused by exposure to these drugs that have the sulfhydryl compounds. The other answer choices that were not correct included curcumin. It's been found to be beneficial in decreasing cardiovascular risk, as well as inflammation and symptoms of inflammatory arthritis. It has not been found to cause any problems with insulin autoimmune syndrome. Cannabinoids may actually increase appetite and potentially cause weight gain. There are a lot of potential therapeutic options for this. We've reviewed some of them in our recent episodes of Dermasphere, but not any problem with insulin autoimmune syndrome. Acupuncture can cause localized argyria or granuloma formation, as well as sclerosing lipogranuloma, and benfotiamine can cause upset stomach, nausea and dizziness, decreased blood pressure. It does contain a sulfur, but not a sulfhydryl compound, so you should be careful about it in patients who have a sulfur sensitivity. If you've not heard of benfotiamine, this is basically a highly bioavailable form of thiamine, and it's beneficial in some patients with neuropathy. All right, this actually came out of a hospital consult, this question. So I wanted to highlight knowledge that had come somewhat painfully to us and hopefully help other people see that coming if they needed to. So you're involved here in the care of a 23-year-old woman who presented to the hospital's emergency department with headache, fever, meningismus, and a underlying altered mental status. CSF examinations showed pleocytosis and elevated protein, but there was no evidence of infection with bacteria, fungi, or viral agents, and serologies did not show a flare of her underlying lupus. You made a tentative diagnosis of drug-induced aseptic meningitis. So which of her medications is the most likely culprit? And I think in the pretest that y'all were sent, it had a little problem because it couldn't have more than 5 answers. So I apologize if this one was hard to answer. This is a design of question that many of us did not have exposure to when we took our boards, but the newer boards include these where they have to pick more than one correct answer and more than one answer choice might be correct. So the choices I gave you were naproxen, mycophenolate mofetil, belimumab, hydroxychloroquine, methotrexate, pentoxifylline, and glucocorticoids. So the right answers you could have chosen included naproxen. You could have chosen also methotrexate and pentoxifylline, as well as glucocorticoids. So this is an article here reviewing drug-induced aseptic meningitis from this French pharmacovigilance database analysis. As you can see, NSAIDs feature prominently as potential causes of these unfortunate reactions, which is kind of awful because these poor patients have something like a headache, and then the medication they might take might potentially keep making it worse, which is kind of sad to think about. Other drugs that are relevant to us, some monoclonal antibodies, potentially some other antibiotics, and other compounds. So the symptoms of this condition are headache, neck stiffness, nausea and vomiting, photosensitivity, and fever. These are all things that we would suspect meningitis for, but then the tests and serologies are negative. And this is a sort of table of the drugs that they highlighted in this study. So we see NSAIDs again featuring quite prominently. We also see monoclonal antibodies, including ones we use to treat patients, such as adalimumab and cetuximab. We can see methotrexate as an anti-metabolite potentially causing drug-induced aseptic meningitis, as can glucocorticoids. So here we've got our correct answers. Following medications have been indicated as the possible causes of drug-induced aseptic meningitis, including intravenous immunoglobulin, NSAIDs, vaccines and antimicrobials, antimetabolites, including methotrexate, corticosteroids, and pentoxifylline, which is a drug I still like very much, just one case of reporting in that particular circumstances. Drug-induced aseptic meningitis can mimic infectious processes and as well as meningitis that are secondary to systemic disorders that we use these drugs to treat, which makes the picture kind of murky and difficult to navigate. So if you're not aware of this potential cause of these symptoms, you might not be able to tell if the patient had the condition related to either the inflammatory condition or to the medicine that they were taking for it. And finally, I know that our colleagues who write board review questions, as those who also help us maintain our certification, like questions about pigment deposition. And so we have here a beautiful, real clinical patient of mine. He has a long history of cardiovascular disease and diabetes and is on many long-term medications. He presents with this blue-gray pigmentation, and which of the following is the most likely cause of this finding? Is it cyanosis, deposits of iron and melanin, deposits of lipofuscin, deposits of homogentisic acid, deposits of fine metal particles in the adnexal basement membranes, or deposits of amiodarone? And so the right answers here are actually deposits of lipofuscin and deposits of amiodarone because of recent data. So here we can appreciate that the pathogenesis of amiodarone-induced pigment and photosensitivity has been studied by the BJD, amongst others. They've used some new methods to help assess the tissue levels of amiodarone and its metabolite, which is kind of hard to pronounce, but I shall try. We have fun on Dermasphere sometimes pronouncing names and chemicals and all sorts of things. So this is the desethylamiodarone. And so the amiodarone pigmented skin actually have drug and metabolite concentrations 10 times that of non-pigmented skin. It is an iodine-rich drug, and its metabolites can actually be detected in secondary lysosomes by energy dispersive analysis with X-rays. And it can cause a phototoxic reaction with an action spectrum in both UVA and UVB wavelengths. This is an article discussing the amiodarone-induced skin pigmentation, where you can appreciate photodistributed blue-gray skin hyperpigmentation. It affects a minority of patients on treatment with amiodarone, and predominantly men. You can see dermal lipofuscinosis with granular accumulation of the lipofuscin in the dermal macrophages. And you can also recently see described in our literature amiodarone deposits themselves with electron microscopy and high performance liquid chromatography. The discoloration can persist for years, but can gradually fade after discontinuation of the drug. So here is a patient here who has this blue-gray skin, and predominantly in his sun-exposed areas. He has ceased treatment with his amiodarone and has significantly improved after 1 year. Our incorrect answers included cyanosis. Vascular syndrome is one of the hot topics in dermatology. It is so hot right now, so hot. So vascular syndrome, recently described, it is a benign vasomotor dermatosis. We actually had a patient with this in our grand rounds that presented, and it was quite striking to see this patient's urticarial-like and cyanotic eruption kind of progress in real time. So one of my residents, who is a TikToker, made a time-lapse video so we could just watch these lesions change over time for this patient. You can see that they have beer anemic spots with cyanosis and urticarial-like eruption. Cyanosis would be unlikely to be persistent and would fluctuate with time. So the question stem made that unlikely in that patient. Deposits of iron and melanin was an incorrect answer choice and a distractor as well. So this is a patient of mine who has, of course, minocycline-induced pigment change. And this is their actual pathology, where you can appreciate this granular deposit that contains both iron and melanin. So here, Prussian blue highlighting the iron deposits, and here Fontana Masson highlighting the melanin deposits. You can see this in both type 1 and type 2 minocycline hyperpigmentation. The type 3 minocycline hyperpigmentation is just melanin, and that's that muddy color that gets distributed on sun-exposed areas. Other incorrect answers included homogentisic acid. We can see this with exogenous ochronosis, and we get these lovely banana bodies deposited here under the microscope, which are quite pathognomonic for this condition. An unfortunate condition, as there's really nothing you can do about it. There's not really a described treatment that really improves these patients significantly, although I do wonder if repetitive microneedling or maybe CO2 laser in appropriately selected patients might facilitate some breakup and dispersal of the pigment in these deposits. So homogentisic acid, a cause of exogenous ochronosis. Another incorrect answer here were the fine metal particles in adnexal basement membranes. So here you can see these brown to black granules in the basement membrane of the sweat duct epithelium. They're very, very fine, and this can be seen in patients who have argyria. So this is another cause of blue-gray pigmentation on the face. I had the great good fortune of training at the Cleveland Clinic, and Allison Vidamos, who was our chair at that time and still is the chair, was actually a pioneer in treating patients who have argyria using fractionated laser as well as tattoo lasers, and being able to sort of break up that pigment and restore normal color to these patients was kind of a fantastic thing. So I have been so excited to be here with you this morning and share knowledge and learning. One of my favorite things about Dermasphere is that I learn new things every week, and I get to put those into practice, and I get to pimp my residents about them and hopefully help them to be better dermatologists in the future. So thank you guys so much for your attention. And if you have any questions, I'd be happy to take those at this time.
We'll look into the chat. I think there's a question about, accessing the podcast. So I don't know if you or Luke could kind of respond to that maybe in the chat so that they can see how to access those or speak to that. But any other questions either for Dr. Tarbox or Dr. Johnson about those first 10 questions? I guess to my own question, Michelle, I trained at a center where we were a referral center for vitiligo, and there was some discussion of use of alpha lipoic acid along with narrowband UVB, particularly for that condition. It seems like from the reports, this is a relatively rare thing, though obviously something that can be very serious. How do you counsel patients who might be on this agent, or even if you're recommending it for specific conditions?
So actually in that article that was looking at their expert opinion, they talked about assessing for risk. The greatest risk population actually has to do with certain HLA haplotypes that are more prevalent in Asian patients than in any other patient subgroup. So they're actually quite rare in patients that don't have Asian ancestry. If you were treating a patient that did have Asian ancestry and you wanted to use the alpha lipoic acid, I think discussing with them the potential symptoms of the insulin autoimmune syndrome, discussing with them that is very rare, but if it happens, we need to know, stop the drug and monitor, and that eventually in most cases it does resolve itself, would be a reasonable informed consent.
Wonderful, thank you. Any other questions from anyone in the group? Oh, there was one in the chat that asked, for patients on metformin, do we need to monitor B12 levels?
I think so long as the patient doesn't have another setup to be B12 deficient, you can just do gentle supplementation for most patients. And I do find that B12 supplementation in the young female patient cohort that we often would reach for metformin to treat HS in often will benefit from B12 supplementation. It has some ability to ameliorate some menstrual symptoms. In some patient populations, it's actually a little bit of a mood, not a mood stabilizer, but it's a medication that helps with mood, as well as potential anemia that can happen in patients who have dysmenorrhea. And B12 oversupplementation is a little bit difficult to achieve. So I think that it's a reasonable thing to use like a gentle sublingual supplement. And a lot of my patients that are on metformin, especially if they have any independent risk factors, such as being a vegan, I recommend that for them. And then people did have questions about accessing the Dermasphere podcast. So of course we have our website, and all of our episodes are available on SoundCloud at dermaspherepodcast.com, but we're also available anywhere you get your podcasts. So Apple Podcasts, Stitcher, Google Play. I don't know what the other ones are. Anchor. I'll let Luke go on this one.
Yeah, all that stuff. Though I wonder if the question in the chat was actually how to access the IDS presentations rather than podcasts.
It may have been that, yes, but we're always happy to talk about it. We're 61, I think, or 62 episodes in now. We love helping people learn, and we enjoy it very much when people get something out of the podcast. So if anybody has any other questions about that, we would love to answer them. I don't know how to access the recordings, but hopefully those are easily accessible as well.
Yes, we'll be making those available after the end of the session. Okay, thank you very much, Michelle. I will have you kind of again go in. I apologize, we have to keep doing this, but go in and switch me back to the host.
I will do that. Okay. This full screen. So I hover over your name and I say make host or something like that.
Correct.
Haha, I think I did it. Did it work?
You might have to stop screen share.
Okay, let me stop sharing.
There's always something on these Zoom-based meetings.
All right, now I think it worked.
Perfect. Thank you guys so much. Again, if there are any offline questions for Dr. Tarbox or Dr. Johnson, please don't hesitate to, send those in either via the chat or email. We're always happy to get those. I will also say that Doctors McGinnis and Miller are still sort of on the line as well. So if any questions come up, after percolating with their sessions that you didn't get to ask, we can also take those as well. And any downtime we can use, for some additional questions too. So again, thank you, Michelle and Luke.